All right. Hello, everyone. My name is Tom Kaya. I'm reporting for the FITsontheGO blog on behalf of King's College of London and the ACC. I'm joined by Dr. James Januzzi from Mass General, and he promised me to provide us some insight into the road travelled for high-sensitivity troponin T assay use in the United States.
Yeah, so currently we use in the United States, at least with respect to troponin T, the fourth generation assay, which is not the highly sensitive assay. But about 6 months ago, the Food and Drug Administration approved the highly sensitive troponin T assay for the United States. And so little by little, institutions are now converting over to the highly sensitive assays. We are going to be actually converting on March 21st, so about 2 weeks from now. And this is not just at the Massachusetts General Hospital, but actually across our entire healthcare network. And I think one of the important aspects of this conversion that we have learned working together with our colleagues in the emergency department, laboratory, internal medicine, hospitalists, and others is that this really takes a collaborative effort to get ready for the conversion, to educate, to understand the higher sensitivity will allow us to exclude myocardial infarction in as fast as 1 hour, but also being ready to detect the chronic myocardial injury that will be more commonly detected in our patients and knowing how to respond to that finding.
So, have you got any experience in how many patients undergo troponin testing at the moment at your institution?
It feels like hundreds a day, actually. And I would not be exaggerating if I said that we test probably somewhere in the range of 40 to 50, if not more, patients a day in the emergency department, and probably a similar number in the up in the hospital setting as well.
And have you been involved in designating or designing the rule-out and rule-in pathways for the use in the emergency department as well?
Of course. So through the years working together with colleagues from Europe, you are well aware of the fact that highly sensitive troponin has been in wide use in Europe for the last 8 years, if not longer. Working closely with colleagues in Europe that I've had a wonderful working relationship with, including people like Christian Muller from Switzerland, who has really been a pioneer. We've developed the cutoff strategy for Massachusetts General Hospital that we'll use, which is very similar to the strategy used in the APACE study as well as the TRAPID AMI study. So we will actually be using the 0-1 hour rule-out algorithm, utilizing cutoffs with sex-based approaches. So we will use highly sensitive cutoffs, predicating on high sensitivity for women, using a cutoff of 10 nanograms per liter for women and greater than or equal to 15 nanograms per liter for men. And doing this at the 0 and 1 hour mark. Now in the hospital, we're going to take a slower approach using a 0 and 3 hour approach. And the logic there is twofold. One, there's less urgency to get the patient out of the hospital as opposed to when they're in the emergency department. And also there are less data with respect to the 1 hour algorithm for hospitalized acutely sick patients.
Fantastic. So I imagine the sex-specific cutoffs you're using are for the rule-in rather than for the rule-out. And is it right to say that your rule-out cutoff will be 6 nanograms per liter as advocated from the FDA?
A very good question. So there are multiple different thresholds we need to think about. There is the limit of detection. There is the upper reference limit. So the upper reference limit is based on the 99th percentile, so 10 and 15 for women and men respectively. Those are possibly for rule-in, but there will be many patients that are above that threshold who do not rule in for an acute myocardial infarction. The challenge is looking for a delta, looking for a change. So from 0 to 1 hour, we're looking for at least a 6 nanogram per liter rise or fall in order to identify this as an acute cardiac injury state. So it's not just being above that threshold to rule in. Below those values, you really do have very good negative predictive value. And I should mention that we're going to be utilizing the heart score in the emergency department. So we'll use an accelerated diagnostic protocol, which will increase the negative predictive value even further. Now, as far as the 6 nanogram per liter cutoff, that's the limit that the FDA is allowing us to report, which is the lowest limit before we start to lose precision. It turns out that 6 nanograms per liter does not have 100% negative predictive value the way, for example, using 3 nanograms per liter would. And our hope is that recommendation by the US FDA will change such that we will be able to begin using 3 nanograms per liter rather than 6. So the bottom line is it's going to take 2 measurements before you can rapidly exclude acute myocardial infarction in most patients.
And just one final question, because this is really something, some of the criticism we've faced most of the time when we talk about high-sensitive troponin assays or more novel biomarkers that increase sensitivity for rule-in and rule-out of myocardial infarction. Many physicians, particularly from the US, seem particularly concerned about the repercussions it's going to have on their practice and how to educate their colleagues on the use of troponin. So what was your approach in your center?
Yeah, so aggressive education. What I tried to do in educating my colleagues, number one, is to point out that with higher sensitivity means that we will detect more injury outside of acute myocardial infarction. So it's important to recognize that troponins are not an acute MI diagnosis by definition. One needs to look at the magnitude of change, the absolute value. Very high concentrations are more likely to be a myocardial infarction. The change is important, as I've said, and also keeping the clinical context in mind is very, very important. I will offer a word of reassurance that in Europe, where these assays, and Asia Pacific and in Canada, where these assays have been used for years now, the consensus is that one detects more acute myocardial infarction without a trade-off in doing unnecessary testing and other such things. Christian Muller's group, for example, published a paper. Raphael Twerenbold, one of his fellows, was first author. A paper in European Heart Journal 2 years ago now showing that logical use of highly sensitive troponin shortened emergency department length of stay, reduced cost, reduced the number of stress tests, reduced the number of catheterizations with normal coronary arteries. So really in the end, it actually improved cost-effective care. So I think that there will be a learning curve for us, and certainly there'll be some growing pains. But as we learn how to use this test, I suspect our success will be very comparable to the data that have been shown in Switzerland and elsewhere.
Fantastic, and thank you so much for an eloquent summary on the challenges, but also the benefits you can encounter by using high-sensitive troponin assays. This was Tom Kaya interviewing for the ACC FITsontheGO blog. Dr. James Januzzi, thank you very much for joining me today. If you're up for more videos like this, please join us on the YouTube channel FITsontheGO.